My name is Barry Borlaug, and I'm a cardiologist at the Mayo Clinic in Rochester, Minnesota, United States. Well, we know that about 2/3 of all patients with heart failure and preserved ejection fraction have the obesity phenotype of HFpEF. That is, they have a body mass index of 30 or higher. And we know that the hemodynamic, functional abnormalities, cardiac abnormalities present in these patients are correlated with the amount of excess body weight, body fat in particular. So Summit tested whether targeting this with the dual GIP/GLP-1 receptor agonist tirzepatide could improve heart failure. It specifically could reduce the risk of worsening heart failure or cardiovascular death in patients with obesity-related HFpEF. The primary analysis, which was reported at the AHA meeting last year and simultaneously published in the New England Journal, showed that tirzepatide as compared to placebo reduced the risk of worsening heart failure or cardiovascular death by 38%, and also improved the co-primary endpoint of quality of life by the Kansas City cardiomyopathy score. In this analysis, we looked at the impact of baseline obesity severity, both in a general obesity sense, looking at tertiles of body mass index at the time of enrollment, and also specifically focusing on central adiposity. We know that many patients with HFpEF have an increase in central adiposity, even if their BMI isn't elevated. And this was evaluated using the waist to height ratio. What we found was the baseline body mass index and the baseline waist to height ratio didn't really impact the effect of tirzepatide on worsening heart failure events and the primary outcome of worsening heart failure or cardiovascular death. The benefits were seen very consistently, even in patients with less severe adiposity, BMI of less than 34, as compared to those with a BMI over 40. And similarly, there was no heterogeneity in the effect looking at people with more or less severe central adiposity by waist to height ratio. We also looked at other secondary endpoints, such as the change in 6-minute walk distance, changes in CRP and blood pressure, and changes in KCCQ clinical summary score. And while the differences weren't statistically significant, there was a trend for greater improvement in 6-minute walk distance, a measure of exercise function, and greater improvement in quality of life scores in patients with more severe general obesity or higher BMI at baseline compared to those with less severe obesity. But these didn't reach statistical significance when we formally evaluated for that. We also looked at the relationship between the change in body weight and the change in waist circumference as a measure of central adiposity, and the improvements that we observed in quality of life scores and 6-minute walk distance. And for this analysis, we just restricted to the patients who were randomized to and received tirzepatide, so not including the placebo arm. And what we found was there was a very striking positive correlation. So patients with a greater reduction in body weight or a greater reduction in waist circumference with tirzepatide had markedly greater improvements in exercise capacity and also greater improvements in quality of life. Whereas those with less dramatic weight loss did not appear to enjoy as much of a benefit with tirzepatide. Well, I think that overall these results show that the benefits are observed in all people who fulfilled the eligibility criteria. So namely everybody who had obesity, who had a body mass index of 30 or greater. There are some suggestions that those with more severe obesity may benefit a bit more. Again, although these were not statistically different. But I think this also tells us that after they start treatment, patients that lose the most weight, they're probably going to derive the most benefit. Whereas conversely, those that don't, maybe we need to be thinking about other alternative approaches to help them um, achieve greater reductions in body fat. I think the next steps are to continue evaluating tirzepatide and other novel treatments which are targeting excess body fat in patients with obesity-related HFpEF. Um, Both semaglutide and now tirzepatide in the SUMMIT trial have been shown to improve quality of life and exercise function in relatively modestly sized trials. But there are even more potent drugs that are currently being evaluated that can lead to more dramatic weight loss. Um, and these may hold even greater promise to improve clinical status and reduce um, heart failure related morbidity and mortality. So I think further study is needed with what we have, but also evaluating some of these newer novel medicines.